Right, well, it's 7:30, so I think we'll go ahead and get started. Welcome everyone to Geriatric Grand Rounds. A few announcements before we start. Our next Grand Round is scheduled for November 18th. Our speaker is going to be Dr. Elizabeth Kessler, and she's going to be talking about delivering goal concordant care to older adults with cancer. Next Journal Club will be November 11th, and the presenters are Drs. Melton and Teets. Other announcements, the fellowship ranking discussion will take the place of the Geriatrics Division meeting today following the presentation. So faculty, please join for that. And following today's Grand Rounds, you'll receive an email with a link to the recording of the presentation and the PowerPoint. There will also be a link to an online evaluation, so if you could please take a moment to fill that out, we would greatly appreciate it. Please feel free to submit questions in the chat or the Q&A boxes at any time during the presentation. If it's a quick question, we'll try to get to it during the presentation. Otherwise, we should have time for Q&A at the end. So I'm really happy to introduce our speakers today. We have a joint presentation by Drs. Horney and Jones. Dr. Carrie Horney completed her medical school and internal medicine residency training at Duke University, followed by a geriatrics fellowship here at the University of Colorado. As a physician with the Rocky Mountain Regional VA, her clinical and educational roles are in home-based primary care and the VA's Geriatric clinic. And in her free time, she enjoys spending time with her family, particularly in Colorado's beautiful outdoors. Dr. Theresa Jones completed medical school at Case Western Reserve University and general surgery residency at the University of Colorado. She then completed a surgical critical care fellowship at the Ohio State University and has been a surgeon at the Rocky Mountain Regional VA since 2015. Her other roles include mentoring the chief resident in quality and safety at the VA and OPC assistant clerkship director for the School of Medicine. Her husband, Edward Jones, is also a surgeon at the Rocky Mountain Regional VA, and they have two daughters aged 7 and 5. So we're really excited to have them here talking to us about the Aging Veteran Surgery Program and perioperative care for older surgical patients at the Rocky Mountain Regional VA. So I think Dr. Horney is going to start, so I will turn it over to you.
Good morning, everyone. Theresa and I are so excited to be here to tell you about the Aging Veteran Surgical Wellness Program at the VA. Let me get my slides up and going. Okay, so hopefully everyone can see that slide well. As I was mentioning, we're so excited to be here to talk about the Aging Veteran Surgical Wellness Program. It's a program I'm very proud to be part of. So our objectives for today are to describe what the Aging Veteran Surgical Wellness Program is, to share a little bit of evidence behind the initiative, to talk about some of the successes and challenges of implementing the program, and to talk a little bit about the goals for the future. Neither Theresa or I have any disclosures. So here's the obligatory slide that reminds everyone that our population and therefore our patients are old and getting older. And in terms of surgery specifically, more than 1/3 of all inpatient operations are performed on patients 65 and older. The morbidity and mortality for these patients is significant, not to mention the cost of caring for those patients. This is data from a study out of Washington State. It was a population-based study looking at abdominal operations from 1984 to 2004. And when they looked across nearly every kind of surgery, even after adjusting for hospital volume and surgical characteristics, including whether the surgery was elective or emergent, they found that the risk of mortality and postoperative complications increased with every age group. So we know that age is a risk factor for complications of surgery. So the American College of Surgeons and the Coalition for Quality in Geriatric Surgery put together a geriatric surgery verification program. And the Rocky Mountain Regional VA Medical Center was fortunate to be selected as one of the beta testing sites for the program beginning in January 2018. We had our first site visit that same summer, and we're getting ready to have our next site visit this month. The goals of the program are to provide high value and high quality care. The program includes any patient 75 years or older who's having surgery. And the specific goals are to decrease complications, improve interdisciplinary communication, and enhance the patient and family experience. So this slide shows our team. Just want to highlight that Dr. Tom Robinson is our director and Theresa is our co-director. This is a largely volunteer multidisciplinary group. We also have a quality committee that meets monthly. And I saw that Ethan Kumbler was on this morning, and he's one of the members of our quality committee. So the quality committee reviews the standards from the American College of Surgeons and then also does chart reviews to make sure that we're meeting those standards. Our program was really lucky to be featured in a National Associated Press article in July of 2019. And they highlighted the national program, but they also interviewed members of our team and our patients. And they really just stressed how the standards focus on team-based care and improve communication. So I want to thank Dr. Robinson for this slide. He put it together, and this graphic just demonstrates how the program encompasses all phases of perioperative care, starting with preoperative care, includes the immediate postoperative period, and then has elements that address after discharge as well. So during the next slides, I'm going to go into more detail about some of the elements of the program. I wanted to share a quote from Spring Wright, who I think is also on this morning. She's our physical therapist on our team, and yesterday during our multidisciplinary meeting, she said, "This team has really fine-tuned how they deal with complex patients." And I think that is a very telling quote. So to start out, to talk about what we do preoperatively, focusing on the screening processes. The goals of screening in the program are to identify potentially modifiable factors that could be addressed to influence surgical outcomes, but also can inform decision-making around surgery. When we think about the traditional preoperative risk assessment, it really uses single end organ dysfunction to look at risk of adverse postoperative events and to identify strategies to try to reduce that risk. It really doesn't acknowledge the sum of disease burden that many of our patients have. And it also doesn't take into account the overall reduced physiologic reserve that older patients suffer from. The goals of the Aging Veteran Surgical Wellness Preoperative Screening Program are to identify those additional risks through that geriatric lens. And so we identify patients who are 75 and older who are scheduled for surgery that's going to require an admission. And then we complete preoperative screening, and that can be done either in person or via telephone. And many of the screens that we've chosen, we actually chose because they're able to be completed over the telephone. Our VA serves a very large geographic area, and often doing an in-person pre-op evaluation isn't possible. The areas that we look at in the preoperative screening include mobility, function, nutrition, and cognition. There's also a very robust advanced care planning piece. And then, as I mentioned, we have a weekly multidisciplinary conference to discuss each patient, to identify the areas where they may be at risk and to attempt to intervene. So throughout the presentation, I've shared examples of some of our notes and some of our protocols or order sets. And the reason that I did that is there was a huge amount of work that went into creating the program to create standardized processes through the electronic medical record, or CPRS. And the goal of doing all of that work was to really make sure that each and every patient that's being evaluated by the program was being evaluated completely, thoroughly, and completely. So this is an example of the pre-op screening note, and you'll see that it hits all of those areas that I mentioned before. This is an example of our interdisciplinary pre-op note, just to show how we document the conversations that are happening in that multidisciplinary team meeting. So this slide just summarizes the screens and interventions. I'm not going to go into it in detail now. I'm going to pull out each area and go through it. But I did want to highlight that even though the screens and the interventions may seem very straightforward, we truly believe that when you look at the sum total of what's being looked at, it really makes a meaningful difference for the trajectory of individual patient. I'm going to talk about mobility and function first. So the screens that we use to evaluate the mobility for a patient are a self-reported 6-month fall history and asking about whether they use a gait aid. For function, we use the CATS ADL. And the main interventions that we have for our patients in this area are occupational and physical therapy. We try to refer people preoperatively if time allows. And Theresa is going to talk a little bit about the challenges related to that later on. We also really focus on both early therapy after surgery and early mobility after surgery. And I also think that for mobility and also function, doing these screens ahead of time really helps to inform planning around discharge. Often we're able to identify patients we think are very likely to need rehab and get those conversations started early. So just to provide a little bit of the data or evidence behind why we do these particular assessments. So mobility, the use of a mobility aid, falls and slowed time up and go are associated with increased surgical risk. The studies for both falls and slowed time up and go came from our group at the VA. Early post-op mobility has been associated with improved outcomes. And as I mentioned, the baseline mobility assessment is really important to future planning. I did include an image of the timed up and go, but you'll notice we don't use the timed up and go. And again, as I had talked about a minute ago, doing an in-person pre-op evaluation is very challenging in our medical center, and so we've not included the timed up and go. In terms of the evidence behind the functional assessment, preoperative functional impairment is also a risk factor for poor surgical outcomes, including mortality. Additionally, the immobility that's associated with surgery itself can increase the risk of functional decline for our patients. Functional recovery for older adults is often protracted after surgery, just like for any hospital stay, and this period can be further prolonged if it's complicated by delirium. Now I'm going to move on to nutrition. The screens we use for nutrition include asking about unintentional weight loss, assessing if there's new swallowing changes or swallowing difficulty, and reviewing the albumin lab. And in terms of the intervention, we have the ability to consult nutrition both preoperatively and immediately after surgery while the patient is inpatient. In terms of why nutrition is important, malnutrition is common and often under-recognized in older adults. There was one population study that looked at how common malnutrition was in older adults in various settings, and they found that in rehab patients, over 50% had evidence of malnutrition. Malnutrition is also associated with increased surgical risk, particularly infections and wound complications. There's some evidence that shows that preoperative screening and nutritional optimization can improve outcomes, in particular length of stay. So the last area that I'm going to talk about in terms of screening is cognitive impairment. And the way that we screen for cognitive impairment in our program is with the 6-CIT. I know this is a little bit less common of a screening tool, but the reason that we use it again is because it's validated to be used over the phone. In one validation study, it had similar performance to the MMSE to give you an idea of sort of how the screen compares to other ones we might use. In that validation study, it had slightly better sensitivity and similar specificity to the MMSE. I'm going to talk about this a little bit more on the next screen, but I did want to mention that I think one of the things that happens with doing these cognitive screens is that it really helps to facilitate discussion and communication around planning for the postoperative course. I think also it really allows us to highlight to make sure that appropriate consent has been obtained. And so there's this overall communication piece that happens with doing the screen. The other interventions that we have are that if the veteran is enrolled in primary care at the VA, then we're able to refer them to the primary care mental health integration for further cognitive impairment after surgery. And that's to verify and further diagnose whether what we're finding on our preoperative screen is true or not. And we're also able we have a very robust plan to notify the primary care providers when these screens are abnormal. So in terms of why we think about cognitive screening, preoperative diagnosis of dementia is associated with an increased risk of post-op complications, including those I've listed here: acute renal failure, pneumonia, sepsis, stroke, and urinary tract infection. Cognitive impairment is also a known risk factor for developing post-op delirium. And that cognitive impairment and delirium act synergistically to increase the risk for long-term functional decline in our patients. So those are the preoperative screens that we complete. I just wanted, again, as I mentioned with the cognition, to just talk about how the results of doing these preoperative screens and meeting and the interdisciplinary meetings goes above and beyond just identifying the risk factor and doing the intervention. And that is one of the things that happens, is that these preoperative screens are often completed by the primary surgical team. And that ensures that the appropriate team members are aware of the areas of high risk for each patient. And the interdisciplinary team meetings that happen weekly also allow for creative problem solving and added communication between all of the disciplines. Another component of the program that happens preoperatively is the life-sustaining treatment decisions initiative. And so the VA had rolled out a national initiative to standardize conversations and documentation around advanced care planning. And our team's been very fortunate to work with our local leaders of the LST initiative to integrate the framework for LST within our program. And as a result, there's been broad adoption of these processes across surgical services and a true change in culture to have these discussions with our surgical patients. The components of the LSTDI include discussing and identifying a surrogate decision maker, eliciting understanding of diagnosis and prognosis, ensuring the veteran understands their diagnosis and prognosis, focusing on their values, goals, and preferences, reviewing any existing advanced directives, and then providing additional basic information about advanced care planning. Also mentioned that we've been really lucky to work closely with the advanced care planning group visit team at the VA, and they've been a wonderful resource for our patients. So once all of the preoperative screens have done and the patient is ready for surgery, then they have surgery. And Theresa and I felt that no presentation was complete without a Far Side comic. So what happens after surgery for our patients? It really, the post-operative care really is bread and butter geriatrics. Our inpatient care program consists of two main parts. One is systems changes that have been put in place to ensure that appropriate evaluation and management of geriatric issues is happening. And I'll talk in more detail about these in a few slides. The other piece is the direct patient care. So we have an awesome aging veteran nurse team that does daily rounds on our patients. They review the delirium screening that the floor nurses are doing. They make sure that our veterans have their appropriate sensory equipment. They make sure the right consults and protocols have been entered on every patient. They make sure that goals of care have been readdressed by the primary team if there's a change in care plan or escalation of care. They also participate in the discharge planning and share much of the conversations that happened preoperatively with the discharge planning team. And then they report to the ID team every week, which really allows for, again, this communication and problem solving to occur. Additionally, they write an awesome discharge note that is a summary for the primary care provider. So I'm going to share more of those notes and protocols from CPRS. So this is the daily rounding note, and I mentioned many of the things that our rounding nurses do for our patients, but I also will just highlight that we do it's not just a functional assessment, but also looking at whether there is new functional impairment that's happening day to day. There is a braid-in to make sure that our patients aren't developing any pressure sores. They review tethers. They look at nutrition and hydration, and then they also do a medication review looking at total numbers of medications and whether the veteran is on any BEERS medications. Now, there was a very robust geriatric evaluation. This is our delirium prevention protocol. You'll notice that it has much of the evidence-based interventions included in there. So minimizing disruption overnight, making sure again that our patients have their sensory aids, and then focusing on reorientation, including educating family about that. This is the delirium assessment and treatment order set. And so if a patient develops new delirium, the goal of this order set is to trigger thoughtful evaluation by the primary team around why that might be happening. This is our multimodal pain pathway. And it was created in order to promote appropriate pain management, but with a goal of minimizing centrally acting medications. And also to highlight the importance of evaluating potential complications of pain management, in particular constipation. This is the mobility order set. You'll notice that it's a staged mobility program, starting with that's completed by the floor nurse, that starts with sort of lower risk mobility, and then as the patient succeeds at each stage is able to move higher. And our goal is, again, to really promote early mobility and as much mobility as possible for our patients. So we hope with our amazing rounding team, the care of the primary team, and the protocols that are in place, our patients have an uneventful post-operative course, and then they get to discharge either to home or rehab for further strengthening. So what happens after discharge? So after discharge, there is a postoperative phone call or VVC visit, and for this phone call or VVC visit, it includes elements of traditional post-op follow-up, like the wound check and making sure our patient's pain is being managed, that they have appropriate scheduling with the primary team. But also it includes the same elements of a geriatric evaluation, making sure that the patients are functioning and moving around okay, that they're eating all right, and then looking at their medications with a geriatric lens. So here's an example of the post-op phone call note. And again, you'll see that everything is just very standardized to make sure that every patient is getting asked about every element of the program. Here's the second page of that note. Now we're going to move into talking about some of the successes and some of the struggles. And I'm going to hand the slides over to Theresa after sharing the first win. And the reason that I wanted to share the first win is because, as I mentioned, I'm really proud to be part of this team, and it's been just such an amazing learning experience to be the geriatrician on a program that is surgery driven. And one of the things that I've really noticed over the 3 to 4 years that the program's been in place is that there's been an overall cultural change within the medical center around the surgical care of geriatric patients. There's just so much awareness now of these issues that didn't exist before the program was in place. And that has just been very rewarding and exciting to see.
I totally agree with Carrie. I'm so sorry. Can you guys hear me?
Yep, Theresa, we can hear you.
Fantastic. Sorry for that. But we've really had such an incredible progression and buy-in from the primary surgical teams to complete not only the screening for these patients, but for a lot of other patients too. We have been able to recruit a really diverse interdisciplinary team that meets weekly to have these really great conversations. And for the large part, everyone's a volunteer. Like, I can't give enough kudos to our inpatient rounding team, who was noted by the site visit back in 2018 as the biggest strength of our program. One important thing to note of our group is that it's largely FTE neutral. There's only one designated position. The coordinator for the program is in the surgery office. Otherwise, again, everyone is a volunteer. Lucky for me, I get to talk about the implementation challenges that we have had over the last 3 to 4 years. And I think the most clinically relevant one is the identification of reasonable intervention with the limited preoperative time that we have. As the majority of you guys know, we have a VA scheduling mandate that says that patients have to be scheduled within 30 days for their surgery, or they can be referred out into the community. And this really limits the interventions that we are able to do before surgery in an otherwise reasonable candidate. And of course, in the last couple of years, we've had the COVID pandemic limiting the elective surgeries that we can do, which again limits the preoperative interventions and screening that we can do. Workload. So both a win that I previously talked about and a challenge that our group is FTE neutral. So our staff participating in the program they're doing it on top of their normal duties. And so we really try to limit the daily ask for our staff. Particular challenges we had in the last few years was convincing our floor nurses to do a delirium screen. Interestingly, we were not screening for delirium on our floor patients. And then asking our staff to track the use of certain resources that was required by the program, but that we weren't doing, including tracking non-VA affiliated rehab discharges. And then finally, patient factors, always in there. We have such a large catchment area in Visit 19 that it's really hard to ask patients to travel back for appointments and interventions. And then even with the increase in use of technology with the pandemic, patients have difficulty with technology and the limited support and bad internet in the middle of nowhere. To address these challenges, we are always recruiting new staff. And as we continue to grow the program and we're allowed to make these wonderful presentations, thank you very much for letting us do this, we get more people engaged, which decreases the workload for our current staff, particularly our rounding nurses. I think in the last few months, we've added 3 additional ones, which is amazing. Coincidentally, fortunately, we've had several national mandates at the VA that led to us being more compliant with the standards, including the LST that Carrie's talked about, and actually delirium screening. There was a big rehaul of our nurses' notes, and so now the floor is doing delirium screening. I think this was previously mentioned, to overcome travel challenges, we adapted having the validated phone screen. So if we do miss a patient on their initial intake, we can still do the screening and identify any other interventions. And then lastly, we have found that we've had some discharge issues, not surprisingly, including scheduling, education, and readmissions. And our group is working with the Institute of Healthcare Quality, Safety, and Efficiency at the University of Colorado. We are the VA pilot, and that is that quality program to help improve our use of post-op healthcare utilization. So we're very excited to be participating in that this year. So as part of the standards, we have ongoing data collection looking at our outcomes, including the standard vascular postoperative complications, including infection, rehospitalization, and death. And of course, we look at geriatric specific outcomes, including decubitus ulcers, delirium, and functional outcomes. And we're also tracking their discharge location, length of stay, and now with the addition of that post-op phone call that only happened in the last couple of years, we also are assessing the postoperative cognitive state. We were the first to publish outcomes data for the GSV implementation. This was published in the Journal of American Geriatric Society this year. We had identified a matched cohort through the VASCWIP database, a control group that was matched for age, ASA class, and procedure. And even with a multivariable model that included specific comorbidities, we found that our group had a significantly shorter length of stay compared to the matched cohort. Unfortunately, VASCWIP currently does not keep track of geriatric specific variables, but there is a NISQUIP pilot of geriatric variables in similar surgeries to what we have been keeping track. And we did see a lower rate of delirium, decubitus ulcers, and functional decline. Future directions, still working on it. We're going to have our site visit soon. We're still looking at our outcomes data and looking at our assessment. Currently, we're in the final stages of gathering that data from the COVID pandemic and looking at the impact on our patients and the outcomes. Certainly, we've had more non-elective surgeries and patients who had difficult placement due to the COVID precautions at the rehab centers. We are working on postoperative transitions of care, focusing specifically on communication to our rehab facilities. There always seems to be a big gap there, especially with the non-VA affiliated ones. Working on that. We're working on our growth of the postoperative follow-up, including our VVC clinic and phone calls, and trying to gauge what's the most successful time to contact patients and the most meaningful, honestly. And then the biggest change is going to be patient engagement. We like to have more patients involved with this process. We met with the patient group here at the VA at the beginning of 2020, and we like to involve them in these optimizations or conversations on how to improve our program in the future.
Sorry. Can everyone hear me?
Yes.
Good. All right. So, Theresa, we went pretty fast. So now we're on conclusions. So, in summary today, perioperative management of older adults should be tailored to their unique needs. And the postoperative care should focus on geriatric risk factors with a goal to improve outcomes. And mainly the Aging Veteran Wellness Program is here to help the medical center, help our patients, help the primary teams. This is our reference slide. And now there's lots of time for questions.
All right, so a couple questions coming in. So first of all, just a comment, this is so inspiring, and what you have done represents the gold standard for geriatric surgery nationally. What do you think the most important element needed to start this program in a hospital that has not enrolled in the geriatric surgery verification process?
Theresa, you want me to go first and then you can go?
Yeah, you go.
I think probably having champions in the different areas. So with the surgical teams, with nursing, therapy, nutrition, social work. So having champions that are interested in piloting and growing the program.
100% agree. And as we keep saying, it's all volunteers. So we need people who are really motivated and excited to change the care for their veterans. There's not a lot published on the outcomes of this program, but one of them is an editorial that reflects similarly that the staff really wants to get involved. And I think that's such an important part of this.
Okay, thank you. Another question, commenting that the improvement in function that you guys saw with that data is awesome. What would you say is the driving force on that? Is it the order set to walk TID?
Theresa, do you want to take that one?
I think it's a combination of things, honestly. There's no one thing that has had that improvement, but I think the increased focus on getting patients their appropriate home aids first and then assessing them. Our spring is on here. Our PTOT team has been so engaged and so helpful in developing this. That progressive mobility protocol was developed by them. So I think the extra motivation to get them moving earlier is really what benefited them.
I was curious, I had a question about whether, as part of your preoperative evaluation, when you're looking at these cases, does it ever affect decision-making regarding whether to even proceed with surgery?
Yes, it has. And I think, I don't know, Theresa, you can speak to it, how often it happens. I wouldn't say it's super frequently, but I think the conversation around that is just so much more thorough. And because of the identifying the various risk factors and maybe with cognition being the main area, but yes.
I know specifically with patients who are high risk for mortality after surgery, it has changed their decision making. We specifically also look at those patients who are high risk 30-day mortality, and we found that if separately reviewing those patients, we change decision making over half the time, whether it's to delay the surgery or change the type of surgery. But for most of these patients, like I said, there's not much that we change beforehand. It's just that awareness around the perioperative period that has really improved for them.
Other questions? Feel free to type those into chat or Q&A. don't see any more. You guys are fast. Well, if there aren't any more questions, just fantastic job. That's a comment that came in for both of you. Thank you so very much for presenting today. This was really, really exciting work, and you'll be excited to hear more as you go on. For all attendees, thanks for joining, and please take a moment to fill out the evaluation that you'll get by email link. Thank you both.
Thank you.